Hello, Patrick McKeown here. Thanks so much for supporting our Buteco Clinic channel. Can I ask you a big favour? Would you mind subscribing? And with this, we can support the channel more, we can put out more videos, and it would really mean a lot. Buteco, for me, has been life-changing and life-changing for the people that we're working with, and we would love to see it getting out there. So please subscribe. Thanks very much. I'm here with Dr. Mark Burhenne, and it's a name that I've come across many, many times over the years, and I'm sure you've come across many, many times over the years. And Mark, if I can call you that, you know,
Please.
the whole aspect of breathing, and I'd love to get your backstory, by the way, how you got involved with it. You have a massive following on YouTube or on Instagram, one of the social medias, and I'm totally envious. So obviously you've been putting out good messages, and let's put out some good messages now for our listeners, for our followers.
Absolutely. I got into breathing because I wasn't breathing properly. I mean, it's the old same old story, except I had a little bit of an academic background. You would think that dentistry wouldn't necessarily be that type of academic background that would involve breathing, but as it turns out, it is intimately connected with breathing. And so my wife and I, and this was the topic of our of my first self-published book. Um, And at age 40, 41, we were dropping off our first daughter, first of three, in college. So it was the first time we had all been in the same hotel room. We were all dropping her off together. And I literally woke up in the morning being beaten by my daughters with pillows, saying, Dad, what was that noise? It was so noisy we couldn't sleep. Long story, but it's the first chapter in the book. It turns out that my wife and I were both snoring. We were both fit. I was doing a lot of mountaineering and mountain biking and 5-day ski trips in the high country, and she was very fit and petite, and we both felt healthy, and we were eating well, but we weren't breathing well. We both had sleep apnea. She actually had severe sleep apnea. She had an AHI of 34 and a half. I had an AHI of 12. Right. So, and we were both able to breathe through our nose, and we weren't mouth taping then, but if we had, we would have been able to because we were obligate nasal breathers. But it was enough. Let me take my case. So 12 apneas per hour, that doesn't seem like much. But when I corrected that with an oral appliance, and I went to see physicians, and that was part of the reason I wrote the book because that was a very frustrating process. I had to convince them that I needed to be treated. And I was treated, and then finally I treated myself with an oral appliance. I reduced my apneas to zero, again verified by a PSG polysomnography, and my life changed. I mean, and I don't want to be too dramatic, but it was dramatic. It was, I stopped napping. I went to bed earlier, not later. I felt better. I lost a little weight. I think my Vmax, which I'm always constantly monitoring and working on, improved. My dietary choices changed. Less carbs. Wasn't seeking that big energy hit at 1 o'clock or 4 o'clock p.m. after lunch. So again, it's a personal story, and it came out of left field for us. Again, and she's also a healthcare practitioner. She's has a nursing background and then was in biotech for a long time. And even though we knew a lot about health and we were, I don't like the word hacking, but we were optimizing our health and we were taking supplements and we were exercising, we didn't know about sleep apnea. And it came out of left field, and it really put us back for a few years until we corrected it. Roseanne was able to correct hers. She has an AHI of 0 to 3, and it helped her. All of her nasal congestion, need for antibiotics, postnasal drip, sinus infections, all of that went away and never, ever reappeared.
Okay, there's so much in that. And I imagine that there's so many families and they're in the same place. So the
Definitely.
daughter picks up that both of you are breathing hard during sleep. You're snoring and possibly stopping breathing. I'm not sure if she picked
Mhm.
up on that, but it was enough for you to go and do a sleep study,
Right.
and results came back. So you were either stopping breathing or having a reduction in the flow of your breathing 12 times per hour of sleep. But your
Yes.
wife at 34, That's huge, especially for a
Yep.
female, because
Yep.
typically sleep apnea is considered a male disease.
Yes.
And here your wife is having severe obstructive sleep apnea. Um, Thanks also for mentioning the whole thing about food choice. I think that people don't pick up on that. So
Hmm.
it's very normal though, if we're tired during the day, we're going to gravitate towards foods that give us instant energy, but they're not
Right.
going to be the good foods. They're going to be the bad foods. And that in
Right.
turn then, because hormones are messed up with the sleep patterns, we eat more, we eat the wrong foods, we put on weight, and that feeds back into it. And it's almost like a vicious cycle. So then you got a mandibular advancement device, which is a dental device that's worn and it's designed to bring the lower mandible forward by just enough to help open up the airway so that the airway doesn't narrow during sleep. And that got you in. Yeah. How many dentists and orthodontists came into breathing and airway and sleep because of their own issues or because of their children's issues? It's huge. But it just says, why isn't it being taught at the universities? But anyway, I won't even go there. So let's come back to, so you were intrigued then. So you obviously went down that route a little bit more and you went deeper
Mhm.
and deeper.
Yeah, I mean, you're right. That started a whole new world for me. I could call it kind of a functional approach, functional dentistry, although I was kind of doing that in other areas. But this was a big one. And it took me a while. There was no actual tipping point, but I realized over time that dentistry had a unique opportunity here. We were able to recognize sleep apnea well before most other professionals, except for breathing experts like Buteyko experts, myofunctional therapists. But the irony is that dentists weren't really using myofunctional therapists
Oh, I would
properly.
say the dentist is way ahead of us because you're looking into the mouth. You're able to identify all of the risk factors. Okay, myofunctional therapy. Yes, they're looking into the mouth.
Right.
So, and that's like, and the other thing that I would say is that men typically we're at the higher risk, especially once we're over
Yep.
40. We
Right.
don't go to the medical doctor very often, but we do go to our dentist every six
Yep.
months.
Yeah.
And a
Only
dentist is
half,
looking
only
into the
half,
mouth.
only, yeah, that's true. And we are trained in such a way where, so if I go to a party and I meet people that I've met for the first time, and I've been elbowed many, many times by my wife for this. I mean, I can recognize this, and I may go into that conversation pretty quickly based on facial type, retrognathia, bruxism, grinding, mouth posture, lip posture, even neck posture, um, and and it kind of drives me nuts because I know that that person, and again, 90%, I think it's 90%, it could be higher, 90% of sleep apnea is undiagnosed here in the US. I'm sure it could be worse outside of the US. I don't know. And it's so sad because, and again, as I realized in my career, that I'm seeing it every day. I'm seeing it in infants. I'm seeing it at the first visit with the child. I'm seeing it in my retired patients, in my 40-year-olds, my healthy 40-year-olds when I was diagnosed. You name it, it's there, but no one's saying anything about it. So I kind of jumped on the bandwagon, started pushing hard on this, linked bruxism to sleep apnea, although I was going to a lot of courses at the AADSM, American Academy of Dental Sleep Medicine. That's where I got my training, which was incredible and incredibly interesting to me. And what happened there is that I learned that sleep was part of dentistry, part of medicine, but there was a division between the two, and that if I could cure someone's sleep, I could actually cure some oral diseases and other systemic diseases. So again, it's the, I mean, if you take the human skull, and this is a well-formed skull, it's these little, I don't know if you can, it's these two little apertures back here that are crucial, and that little septum, that little vertical piece. And in dental school, I got this view of it. We had a skull. We would take it home every day and study it and learn all the parts and pieces. But it was never clear to me in dental school that that is the primary airway. That's where we get most of our air. That's where we should be breathing mostly. And that posterior nasal aperture is defective in most of us, probably 50, 60%. You may have some numbers on that as well. I think it's underdiagnosed, and it's because of the way the face is developing. When this doesn't expand, this little septum crinkles. In other words, it bends, And the palate, which is the floor of the sinus, is V-shaped. And when that V-shaped occurs, these two holes narrow, they get smaller. And then all of a sudden, you're forced to pull more air through your mouth, which has a cascade of effects on that. But the question is how did we get here? But I'm seeing that now more and more, and a lot of dentists are too. But then there's this problem where we refer the patient to the physician because we cannot diagnose sleep apnea. And we cannot treat it unless we get a diagnosis from the physician. But the physician is incentivized not to prescribe a PSG. It's an expensive test. We can talk more about that if you want. Each medical system has its own way of doing that. And especially if you're healthy like I am. I mean, I had to lie on my Epworth test to get a sleep study. My wife didn't. She had other comorbidities that allowed her to do that. The other thing you can do, and I mentioned this in my book, is, when you check off how likely are you to fall asleep while driving, go to the extreme. I mean, it's likely that it does happen, and most people, most men, check low on that list because we're tough, we can handle it kind of thing. So anyway, that's the problem, is a lot of these patients would get sent back. And I knew that they had sleep apnea, but they were told by the physician, you're fine. Your adenoids are fine. You'll grow out of that. It's not blocking your airway. And if it is now, that will go away over time. That was with children. So that was very frustrating to me. So I bypassed that whole system. I went directly to a Princeton-trained sleep doc that was working outside of the hospital in a private office. And I asked him, how do we fix this? And he was very forward thinking. And I said, I could be one of your biggest referrals or referrers of patients. And I'm pretty good at recognizing sleep apnea. In fact, I would say that I'm 98% correct. And it turned out that I was that. There were like two cases that were borderline, an upper airway resistance syndrome case on a very thin, healthy Asian woman kind of thing. And later we discovered that there was an issue. So that worked out very well. So I would fill out the form. I wouldn't sign it because I couldn't sign it. I would give it to the patient or send it to the doctor, which is a few blocks away. And then he would look at it, sign it. The insurance company would approve the PSG. They would get the PSG, and then from there we would decide whether it was a CPAP or an oral appliance, and then I would refer my patients to a ENT that I helped kind of train in terms of looking for what would work. When they did the nasal endoscopy and the Mueller's maneuver or modified Mueller's maneuver, I showed them what I was looking for. So if the upper part of the airway, the nasopharynx, oropharynx, opened up with mandibular advancement, as opposed to pushing the jaw back, I asked for a number in percentages of how big was that difference. If it was over 50%, I would make my mandibular advancement device. And the insurance would pay for most of it. We figured that out. Medical insurance. This was a dentist billing medical insurance. And this was 15, 20 years ago, and it was working. But what a painful process and the circumnavigation of all these complexities in the medical system. So again, facial development is such a big issue that dentistry needs to take charge of this. I think we should be able to diagnose sleep apnea. I think we should be able to order PSGs. Again, I think we're quite a ways away from that. But if we're catching it and able to see it in 1 and 2-year-olds or younger, why aren't we treating? Why are we waiting for that orthodontic phase, that typical orthodontic phase at age 13 when the jaw is fully developed, and then taking out teeth and straightening the rest of the crooked teeth? It's ridiculous. So yeah, dentistry needs to play a bigger role in this. And again, we have the advantage. And let me say one more thing. We need to work more with myofunctional therapists and breathing experts. And dentistry, you say we're better at it. I still think there's an issue there. I think a dentist that is not working with a myofunctional therapist is working below the standard of care.
I think dentists are in a better position to identify the risk factors associated with sleep apnea, such as scalloping on the tongue, the high narrow palate, the retronaty of the jaw,
Right.
possibly mouth breathing, than
Definitely.
we as a breathing educator. There's so much in that. I don't know even where to start.
Mm.
What's your take then? So you're saying that the human face is changing. It's getting smaller. What would you put down as some of the factors that are actually causing underdevelopment of the face in terms of airway?
It's a critical question, and I wish I had a complete answer for you, but we can go over what I think it is. It's multifactorial. Um, it's probably it's diet. Let me just review it, and then we can get into the details. So it's diet. It could be the quality of air we're breathing, lack of breastfeeding, and not just lack of breastfeeding. It's proper breastfeeding. It's also a dis. It's a lack of a healthy oral microbiome, and that does connect with an interchange or a feedback loop with breastfeeding as well. The first colonization of the human body is via breastfeeding. Um, that's the first biome, essentially. It could be and then from there, the gut gets colonized from the baby swallowing its own saliva. And that's pretty crucial for development and for nutrition. And nutrition is key in making this jaw wider. The most critical, and there are other components, but the most critical component over time in those first 5 or 6 years is this width here. So you're looking up at the upper jaw, and this distance, it can be narrow or it can be wide, and that's called the intermaxillary distance. It's measured. It's typically 36 to 45 millimeters, depending on gender, age, of course. And if that doesn't widen, and this is a box, I try and simplify this as much as possible. There's the mouth box, and then there's the nose box, and then there's the airway box. And this is the one that's very plastic and moving and moving widthwise and forward and downwards. You always see little kids and they look like they're wearing dentures, right? Well, they don't have teeth. Their vertical dimension is decreased, but that jaw hasn't fully grown yet. So if you get good development and good development and width and downward growth and forward growth, that forward growth comes from sucking milk out of the breast. Part of it, it's also from chewing hard foods, not soft baby foods, pureed foods. Um, if that box goes to its full potential, instead of being a narrow rectangle and it's a box, it's square, then the other two boxes follow along. So your airway is more open, your nasal passages are more open, maybe there's more surface area for producing nitric oxide. I mean, it's so complicated that it's difficult to talk about, even to other professionals.
Yeah.
So what are the causes? I would say the whole breastfeeding thing has been interrupted. You know, women in the workforce, I feel very uncomfortable talking about that. Breastfeeding is very difficult. I've seen my wife go through it. I've seen one of my daughters go through it. It's not an easy thing, but somehow we have lost that ability to do it well. And it's not just about the milk and the prebiotic and the carbohydrates in the milk, the complex carbohydrates in the milk. It's way more than that. In fact, I would say that the development of the face from breastfeeding is more important. That's controversial. The texture of our foods. What do babies, if they're not breastfeeding, or if they did breastfeed properly, then what are they chewing on? What promotes that growth? It's mechanics. It's the hardness of foods. Our foods are not hard. They're crispy in a bag. They are soft in a little package. They're pureed. They're also highly processed. Highly processed foods means that it's been broken up into a softer material. It's been broken down. The nutrients aren't there. It could also be a lack of minerals. We need minerals. We need K2 and A and D3. It's lack of sunshine. These are all the bone building products. Also collagen. Collagen is part of that as well. Our foods we're not eating all parts of the animal anymore. Where are we getting our collagen? Maybe from a supplement. Maybe, you know, if you're eating branzino or my favorite are sardines or anchovies in a can, you're eating the bones. You're eating all the collagen and all that. That is so important. Very few people are eating that. Most kids are not eating a can of anchovies, unfortunately. My kids did, and my grandkids are eating them. Of course, we have to do the OPA sprinkles, like a little salt or, you know, a little extra special things and dress it up a little bit. But so it's also probably toxins in our environment and anything that affects hormones. Hormones obviously are part of the growth cycle. I think I did a podcast episode once on microplastics affecting the development of teeth. there's a mechanism there. I can send you, if I mention any studies or episodes, I can send you all the links to that. That was a surprise to me. These are the little white decalcifications that we see when teeth erupt. And it's the first thing parents notice. My kid's tooth is disfigured. There's a white spot. Sometimes it's a brown spot. That could be from ingestion of microplastics. And that's probably a endocrine disruptor. So there's definitely the environment. Our environment is not very friendly. We're dealing with a lot. And when we hit certain thresholds, growth is stunted. It's impaired. So
So
I mean, did I miss anything? I mean,
no,
this is your realm as
yeah,
well. I
yeah,
mean,
yeah,
what affects spatial development?
yeah, nasal allergies and things like that. But in the
Hmm.
main, we're talking
The
about,
environment,
so it's the environment.
allergies.
So the child then is not feeling comfortable breathing through their nose. Maybe their nose is stuffy. Maybe they have a smaller nasal airway.
Hmm.
You talked about the palate being too high, and that in turn is going to infringe the nasal cavity. So if a child doesn't feel comfortable breathing through their nose, they're going to breathe through an open mouth. Okay, I want to talk about dental health. I know
Hmm.
if I go to the local dentist here in Mycullen, County Galway, the west coast of Ireland, I'll probably see a poster on the wall for Colgate toothpaste, oral
Hmm.
health, all about brushing your teeth. Don't be eating sweets and don't be eating sugar.
Right.
You've a take on it that really affirms what I think is absolutely massively important. And how has this one been overlooked? So, my question to you is, if you have a child who's a mouth breather, but regularly brushing their teeth and eating a
Hmm.
perfect diet, if there's such a thing as a perfect diet, well, a good diet,
Hmm.
will that
Right.
child still be at risk of oral cavities?
The answer is 100% yes. If the patient, if it's a child or an adult, is mouth breathing, that is the number one cause of an oral dysbiosis. The oral microbiome cannot survive in that dry environment. It is desiccating. The pH is lower. There's not enough saliva to buffer
Can we
the
go a little
pH.
bit? I'm going to tease this out. So, when you talk about the oral
Right.
microbiome, so you're talking about the bacteria in the mouth, and that's not
Yes,
all bad. You're talking about the,
exactly. The oral microbiome is a beautiful thing. I mean, we can always refer back to the gut microbiome. I think most of us understand that the gut microbiome is a good thing. The gut microbiome and the oral microbiome are not that much different. They reside on this mucosal lining. It's a biofilm. We've vilified the biofilm in dentistry. That's what all the oral care products are based on. That's what our advice as dentistry is. Remove it, scrub it away, disinfect it, sterilize it, nuke it. All of those things we've been saying have been incorrect. What would a physician prescribe antibiotics for someone twice a day for the rest of their life, like we do with toothpaste? Obviously not. It's the same thing.
can I come back in here? So, what you're talking about is you're talking about the standard toothpaste that we'd see in a supermarket. And
Right.
they're including, is it fluoride that's the main culprit, or what
It's
ingredient inside
fluoride,
there is?
emulsifiers, surfactants. Those are chemicals used to make large batches of toothpaste and to give you that foaming effect, although that came later. They needed the surfactants and emulsifiers. It's like cooking. To mix the product and make it taste better, you need an emulsifier or surfactant. But then the toothpaste companies noticed that their product would bubble, it would foam. But then they put that into their marketing. It's like, oh, our toothpaste foams, because it allows it to enlarge and spread in your mouth. So if your toothpaste is foaming, that's a sign that you have something in there that literally, it's a soap. It destructs, it deconstructs and breaks down the lipid layer of a cell wall. So you're taking down, you're killing cells, and then the contents of the cell will spill out into the body. And a lot of that is toxins. I mean, it's almost like apoptosis. It's a sudden disruption and emptying of the cell contents in the mouth. Then there are essential oils. Essential oils are bactericidal, botanicals. There's no data out there that says that's good for toothpaste and that's good for your mouth. So there are a lot of things. There's alcohol in mouthwash. There's triclosan. There are soaps. There are pesticides. Very very low levels of pesticides in toothpaste and oral care products. These products, I would argue that any conventional toothpaste or mouthwash is probably making you tired and it's making you sick, and not just oral health wise, but systemically. And so I noticed a long time ago, and this is before the oral microbiome became a big topic. And the oral microbiome followed the gut microbiome. It was first completely cataloged about 600 species back then in 2005. Now it's 750. It still grows. Um, but I noticed that my patients that didn't brush with toothpaste and didn't use mouthwash of any sort, unless they were rinsing with salt water or a little baking soda, some people would take xylitol, liquid xylitol, and mix it in with water and swish with that, but they weren't using the conventional oral care products. They were uncannily healthy in terms of oral health. And then I noticed that they were just healthy people. They were thin, they were fit, they were breathing properly, they didn't have any comorbidities like heart disease or insulin resistance, any metabolic disorders. And I started noticing that, and I started treating them differently. I would say, listen, you don't need to come in every twice a year. Just come in every year or sometimes every 2 years. Now, that was a very small segment of my population. This was in the Silicon Valley. And granted, this is an educated group, although I had a lot of blue collar workers as well, and a lot of sick people, and so it was a pretty good cross section. But it was easy to pick those patients out. And sometimes my first question would be, "What's your oral care routine like?" And it would be minimal. And it usually came from a distrust on their part of big corporations telling you that you should kill 99.9% of your germs, Listerine, in big ad campaigns. And they couldn't quite vocalize why it was. It was just a gut instinct that was probably a bad thing. You have patients like that, right? I mean, they know that we're probably being sold a bill of goods, and we are. The use of so 2/3 of Americans use mouthwash twice a day, and that mouthwash, 99% of it, is causing high blood pressure because it's taking down the oral microbiome. We have plenty of studies on that. I can send those to you. The first study I saw was in 2005, so they've been around for a while, and all the subsequent studies have confirmed this. There are new studies now that demonstrate that tongue scraping actually can lower your blood pressure. So there's something going on the tongue with that biome. And again, there are lots of little niches in the body, and there are a lot of biomes in the body, but there are a lot of sub niches of the oral microbiome, and one of them is on the tongue. And disorganizing or reorganizing that biofilm, I tongue scrape every morning, is a good way to get those bugs to start doing their job. One is to produce NO. We can talk more about that later if you want, but it's a vital part of the oral microbiome. It's like brushing your teeth, but using conventional toothpaste, conventional mouthwash. Hopefully, I've supported this. It's making you tired. It's making you sick. It's causing high blood pressure, insulin resistance from mouthwash. It's insane, right?
It's
Yeah.
crazy. So the microbiome is essential for health, and we're talking about the microbiome in the mouth. We spoke that mouth breathing will alter that in comparison to nasal breathing. So there's different bacteria in the mouth as a result of mouth breathing. The mouth is dry. How does that mechanism work? So if you're breathing through an open mouth persistently, you tend to have a drier mouth. If you have a drier mouth, that affects the pH. And
Saliva is key for the health of the biofilm. You need a certain amount of it. You also need a certain pH, like the rest of the body. You need a certain pH in the blood. Otherwise, you get acidosis or alkalosis. You need a certain pH in all parts of the body. There's no difference. The mouth is key. It works very well in a very narrow pH. The problem is that after every meal, the pH drops drastically. It will drop very drastically if you drink like a soda, or if you eat like a box of crackers or candy, of course, because that's a refined carbohydrate, and the bacteria, the wrong bacteria, what we call the bad guys, will consume that and produce a lot of acid byproducts, and then the mouth has to buffer that. If you eat raw broccoli, there's no acid event. So the pH is crucial, but also the amount of saliva is crucial. Saliva contains all the components for the health of the like minerals, enzymes, proteases. It also contains other things for digestion and immune response, all of that. It also has nitrates in it too, which is important for NO production.
This also leads me on that it's because the problem with mouth breathing is it's very hard to define it, but you could have a person who's breathing in and out through the nose during wakefulness. So during the day,
Hmm.
then if they do physical exercise, they switch to mouth breathing because it just feels easier. But then
Right.
during sleep, they have the mouth open again. So
Hmm.
even if you have somebody with their mouth closed for the majority of time during the day, the fact that they have their mouth open, if they're doing long periods of physical exercise or if they have their mouth open during sleep, that's going to adversely affect their dental health. Now,
Hmm.
you're talking about, is it dental cavities? Is it gum disease? Is it
Yeah.
inflammation? Is it
Yes.
bad breath?
Canker sores, halitosis, all of that. Because all of that is related to that dysbiosis. If the oral microbiome starts repopulating, if the biofilm thickens, which it will in a desiccated environment, that changes the nature of what that layer of bacteria is. They become more pathogenic. These are you're supporting some of um, the anaerobic bugs, the ones that don't like oxygen. There's a lot of oxygen in saliva as well. So I do worry about marathoners. You know, a lot of my patients were these racers that would do 100 miles here locally in Tahoe and these endurance races. And of course, I would marvel at that, but they weren't that healthy. And I mean, that's a lot of mouth breathing. Certainly at night, I mean, that's one third of our life. Why wouldn't we want to force our mouth closed if we could? That's mouth taping, of course. And the zinger there is that our saliva glands shut down at night because they're not needed. You're in a very parasympathetic tone and you're relaxed. And so that can promote dryness, especially if your mouth is open. We also lose a lot of moisture by breathing through our mouth. We become dehydrated. A lot of us are drinking diuretics, breathing through our mouth, and we're dehydrated the whole day. That has effects, that has vascular effects. That also has effects on the oral microbiome, your immune system, brain fog, all of that. And then, of course, we buy those expensive electrolytes, and we're hoping that that will, kind of rehydrate us. Some of us drink too much water in response. It's really kind of a roller coaster ride because of all these environmental stressors, and it's crazy. So I'm not saying you shouldn't exercise and you can't breathe through your mouth, although I do a lot of mountain biking in the summer and I try and keep my mouth closed in stage one, stage two, and I try for stage three. I don't tape, but obviously when I'm in stage five, it's the red zone, I call it, on my watch. It's hard, but that's what the mouth is for. It's emergency breathing. I mean, when you look at this, there are two entries of air. That's through the nose and that's through the mouth. Which system looks more optimal for breathing? Obviously, this cavernous, dual entry, cleansing, filtering system with, you know, uh, little enzymes on the lining the mucosa that produce NO gas and kill viruses and all of that. This is really for eating and talking. And in fact, that's how it evolved. I mean, our whole voice box and tongue dropped a little bit. That became a compromise. Our airway is small because of that, but we're able to vocalize better. But that's the breathing system the majority of time. And that's how we were designed. But it's funny, we're not following our design principle. We're kind of doing the opposite and with great consequences, right?
It's considered to be too simple, and yet chronic mouth
Hmm.
breathing, it's so common,
Ah, right.
and it's not just affecting dentistry, but it's
Hmm.
affecting sleep, it's
Hmm.
affecting mental health,
Right. Mental health,
it's
absolutely.
affecting respiratory health, all
There's a
of the major
connection
modalities.
between, yeah, there's a connection now. We're seeing connections now in studies popping up. There's a connection between a dysbiotic oral microbiome, which could be related to mouth breathing. So maybe that's part of it, to psychiatric disorders, even schizophrenia.
Can we talk
So
about that link? So is it that the microbiome from the mouth, so every time then that we swallow, we're going to be bringing that into the gut? Is that the link there, or is there something else going on there?
I don't know. The
Mm.
mechanisms are all over the map. It could be that. I mean, we do produce NO in our mouth if we're doing well, but and that gets swallowed, but that's a delayed response for NO. I'd rather catch it early, not bypass this system, and also enable the gut system of producing NO, especially as we get older. But it could be it's probably a function of many things. A, our sleep is affected, and there's a connection between sleep and psychiatric disorders, poor sleep. Since that's connected to facial development, and mouth breathing and or tongue tie, position of the tongue. I mean, it's where
It's
I'm
all
going with it.
interlinked. Yeah, yeah.
My
No, I
God,
get it.
it is,
Yeah.
yeah, yeah,
Nitric oxide. So NO you keep referring to as nitric oxide, and I think in 1993 it was referred to as molecule of the year. And the individuals who discovered it, and just going
right.
back a
It's
while,
still molecule of the year,
it's still molecule of the year.
right?
They were awarded the Nobel Prize for medicine. The Nobel Prize for medicine, I think, in physiology, that they identified that nitric oxide is a signaling molecule in the cardiovascular system. So
Right.
you're talking about nitric oxide. It is produced in the upper airways. It's produced locally in the nose and the paranasal sinuses. And then you're talking about the effect of that downstream. So I wasn't aware of actually the nitric oxide in the mouth, which is interesting. I always
Mhm.
spoke about nitric oxide from the nose.
Right.
And that was the importance of breathing through the nose because we carry that nitric oxide then into the lungs. And I always thought
Yes.
then
Very important.
uh, that the nitric
Which is
oxide, I
very
thought
important. Yeah.
it's very important. So can you just tease out that aspect of it? So the nitric oxide, then you're talking about that in the oral cavity in the mouth.
Right. So it kind of came to me slowly. I mean, I studied a little NO when it came online. And I was always fascinated by it because I'm always looking for overall health optimization. I've been doing that since I was 17, kind of a health nerd. And then I started making connections between NO and the mouth. And then, of course, I already knew that there was some nitric oxide production in the nose. Actually, you taught me that, or the benefits of it and how to optimize that. But then, if you dig deeper in the oral microbiome, there are a lot of bugs, there are four of them in particular, on the dorsal part of the tongue that love producing nitric oxide when exposed to a prebiotic nitrate. And so it's the nitrate, so this is that secondary pathway. There's the NOS pathway, which we lose. That's from the endothelial cells and other areas, I think the gut. And we lose that. We lose that ability as we age, and we lose it around age 40, which I find very interesting because I don't know if you saw that study circulating about a year ago, or maybe for the last 6 months, where we have aging moments. We don't age in a linear fashion. We age suddenly at age 40 and at age 63, 64. And I would say that, and I think a lot of the researchers I know do agree that NO or lack of it, or our ability to produce it or not produce it, is a wonderful way of um, of quantifying, how quickly you're aging. And without it, we are aging very, very quickly. We're getting very, very sick. So so NO can be produced if you feed the good guys. Again, that's why we named our toothpaste company that. It's feeding the good guys. It's always been about feeding the good guys. We talked earlier about all these products that were nuking the good guys and how that produces systemic disease. So first of all, you need to leave the oral microbiome alone. Don't vilify the biofilm, plaque, and all that. Let it do its thing, just like we do with the gut now, or want what we want for the gut. Um, and and in doing so, then these bacteria can come online, scrape your tongue, and then if you feed them the right foods, they will produce this NO gas. This is a system that is in place from birth. Um, Whether we're using it or not is debatable, based on diet and all that, and the use of oral care products, conventional oral care products. But the good news is that after age 40, this continues along. It doesn't tend to wane at all. As long as you take care of your mouth, you can produce NO. You can also produce it on off the mucosal linings of the nose. So really, that's a biome too, the nasal biome, and I include that in this equation. The goddamn mouth is our savior. It can also be our crucifier, right? I mean, it's if you don't take care of the mouth, you're going to age prematurely. You're going to have a horrible life. You're going to have a low quality of life after age 40. So that's the key, is let's focus on that. And by the way, feeding those bugs the nitrates and letting that pathway, that nitrate to nitrite to NO reduction, it's a reduction pathway, which is slightly different than the other one we were talking about, the endothelial cell one. That works to the end of our days, and we should be utilizing that as much as possible because it has such far-reaching consequences. And dentistry should be waving this flag, and this is our realm, and we are the oral microbiome experts. We are the steward of the oral microbiome. At least most of us. I mean, some of us are, not most of us. We're still, the ADA, for example, is still recommending fluoride. Fluoride is antibacterial. Yes, it does topically recalcify teeth, but one of the secondary effects, and I learned this in dental school, is that it was bactericidal. It would also kill the bacteria in the biofilm on the teeth that caused decay, the S. mutan bug, which is not a great way to go. So it's a secondary, here's the problem that we created, here's the band-aid that we're going to apply to it kind of thing. And it causes brain damage to the developing brain. So, and that's still being worked out, unfortunately. But yeah, the oral microbiome is our key to longevity and a better life for those last decades in life. And it's so simple to do. Just use the right products, feed those good guys, obviously eat well, stop mouth breathing. And that's the thing. I always tell patients, if you're mouth breathing, that's something you need to, that's your highest priority. You need to jump on that, whether it's expansion or surgery. If it's a child, expansion, reducing allergies, eliminating those, as you mentioned, anything that affects the airway,
Mm.
adenoids, tonsils, injury, people that get punched can have a deviated septum, genetics, epigenetics, we've talked about that. That is probably, I would say, fix the mouth breathing first. I mean, if you can do that, your blood pressure may drop, you'll feel better. Again, your dietary choices will be better, so you won't suffer from metabolic disorders and insulin resistance over time. So anyway, I mean, I'm
Yeah.
probably beating a dead horse here, right?
Yeah. No, I came into nose breathing. It was just similar to
Hmm.
yourself. I was a chronic mouth breather, and both during wakefulness and during sleep as well.
Right.
And back in 1998, I got a nasal dilator just to help open up my nose. I was doing the nose and blocking exercise to
Right.
decongest it. But I used also then the strips across my
Yeah.
nose, and then I
I use
take my
those
mouth
too.
closed.
That works.
And I remember like the first morning waking up, I don't remember feeling that much different, but the second morning
Right.
was total difference. I couldn't believe it. I'd never experienced waking up feeling refreshed, and nobody
Exactly.
had ever talked to me about breathing through the nose, Patrick. Now, I don't know if it's any different today. Like that's we're talking about almost 30 years ago. So that's what propelled me then to change
Mhm.
my career. I left a degree behind me. I was just after getting a master's degree. I left it behind, and then I started focusing down the breathing route, and people thought I was
Mhm.
crazy. And
Mhm.
people sometimes ask, well, why didn't you go to university to learn breathing? There's no university that's teaching what we teach. You
Right.
know,
Why waste
it's
your time?
so no university is teaching it.
Yep.
Nobody is that I'm aware of, certainly back then and possibly even today.
Mhm.
So coming back to because I know that I've seen some of your, and I want to look at your mints as well, but I've come across that you are a fan or in terms of mouth taping. And I'd love to get your take on it because, we have myotape that we wanted to surround the mouth to bring the
Mhm.
lips together so we can do it safely because I'd love to see this go mainstream. I think it will because really it's going to be driven by people. Um, it's so understudied, nose breathing versus mouth breathing during sleep. It's probably estimated about 50% of adults are breathing through an open mouth. What's your take in that whole thing? Do you identify this with your own patients? Do you recommend them to breathe
Mhm.
through their nose during sleep? And how does it go for you?
Yeah, great question. And starting from current times, mouth taping has become a TikTok sensation, which is not a good thing, and I'll come back to that. So I started before I wrote that book, which I think was 2014, 2015. For 5 years before that, I was using mouth tape as a differential diagnostic tool. I had heard about it. I was very tired of asking mostly my male patients, do you breathe through your nose or your mouth at night? I would explain to them that's 1/3 of your day or of your time on this planet. It would be, and you come in, and every time you come in, you have a cavity, you've got bleeding gums. I would love it if you could start nose breathing. And they're like, what do you mean? I nose breathe. My mouth doesn't fall open at night. Then I would wait for the spouse to come in and she would say, of course he snores, and snoring, your mouth is open, right? So I just got tired of that. And I would go right into mouth taping. And either the hygienist would do it or I would do it. I would first identify that there's an issue. If there's bruxism, scalloping of the tongue, as you mentioned, other features, and if that was present, and health history, of course, or an Epworth, but usually I didn't get to that at that point. I would say, listen, can we try something? I would pull out my mouth tape. I would take my mouth. I would show them how to do it. I would let them tape, and there was a TV in every room. We would watch the news or whatever we were watching. I would say, let's just sit here for 3 to 5 minutes, fully sealed, not myotape or the safer kind of tapes that now I start off with, especially with children. Um, and I would sit there and just pretend, but I would be watching them, and I'd be watching their respiratory breaths and what was changing. And, a lot of them would be like, I can do this, I can do this. And they'd be holding on. But you could tell that their posture was changing, their neck muscles were changing, their respiratory rate was going up. Sometimes they would turn red, or sometimes they would be fine. And then if it was a borderline case, I would give them the roll of tape and I would say, listen, I'm going to text you tomorrow morning and I want to know what happened. And here's what I was looking for. If you slept better, that means you can nose breathe, but your mouth does fall open. If you tossed and turned, but the tape was on in the morning, and again, I'm simplifying, there are a lot of gray areas in between, but the middle area, which confused a lot of patients, was I made it. I had the tape on in the morning, but my sleep was terrible. That means you couldn't get enough air through your nose. You were suffering from hypoxia, maybe some, not apneas, but hyopneas, some riras, but you made it. You're one of those self-actualized people that you're told to do something, you do it. And then there are the people that it's like, well, I don't know, but I mean, I couldn't find the tape in the morning. It was gone. And then I tried it successive nights and I just can't mouth tape. Those patients typically were the ones that were suffering in the chair while we were watching the TV. So that was like a triage system for me where I could quickly get to the sleep apnea, dental sleep medicine treatment part, and I wouldn't waste time. Otherwise, I would just be wasting time. But then I got my diagnosis for sleep apnea, and I noticed that taping was important for several reasons. Airflow, the volume of air going in there. Again, I only had 12 apneas, but if you have a dry mouth and you have this small airway, and the airway dries out and does collapse a few times as you pull a lot of air through an airway that can collapse, it will collapse. But if it's dry, it'll stick. It will kind of congeal. If it's coated with saliva, it will release, right? So that's another reason why dry air was mouth breathing was such a problem. And so I started taping when I was using my mandibular advancement device. And I wasn't advanced that much, but that device prevented me from falling back when I was sleeping on my back, because the jaws weighs about half a pound. And gravity will just pull that down when you go into deep sleep and the muscles are relaxed, not relaxed, they're offline, right? So mouth taping then became a therapeutic for me and for my wife. Then I noticed that my CPAP patients were suffering because when their mouth fell open, the positive pressure was gone. They didn't like the chin straps. They didn't like the full face masks. I would recommend mouth taping with a smaller nasal mask, or just the nasal, I forget what they're called, the apertures, just a very minimal mask. And that was working well. And then I started telling everyone, if you have cavities or gum disease, you should be mouth taping. So it kept going from a sleep airway kind of need to oral health need. And now I think, given that you're the right patient and you can breathe through your nose, everyone should be mouth taping. And my only question there is, from an evolutionary standpoint, why does a healthy person sleep and why does their mouth fall open? Did our ancestors do that? I don't know. I don't know the answer to that. Is it because we're sleeping on a modern mattress? Is it because our CO2 levels in our rooms are elevated? I think that's a possibility. Open those windows, keep your CO2 at 450 parts per million. We have meters in most rooms in the house. I travel with one. I was just in LA in a hotel room. Oh my God, horrible. Bloodshot eyes in the morning, 1600 parts per million of CO2. it's really a hostile environment out there, and our ancestors slept outside. When I go backpacking above tree line, even though it's at high altitude at 10,000 feet, my wife and I sleep so well, even though we're a little anxious because we try not to get into the tent. We're out in the open, we're above tree line, the stars are out, you can read a book just from the light from the Milky Way, no moon. It's kind of a little nerve-wracking, but then when we fall asleep, we wake up refreshed. We have amnesic sleep. That's my number one. That's one of the things I ask patients um, as I'm treating them for sleep. Typically, when you toss and turn, it's a long night because you're conscious, you're awake. Uh, but amnesic sleep, I always, and it's in my book. If you wake up in the morning and you don't open your eyes necessarily, or if you have a mask on, or it's still dark outside and you think, oh, it's probably 1 a.m., but it's actually 6 a.m., that's a good sign. That means you hit deep stages of sleep, REM, delta wave sleep, and all that. So I don't know. It's mouth taping is something that we need to really get serious about
Yeah,
because of
I
our
think so
deficient
too.
cases. Yeah.
In terms of, in order for this to become mainstream, and I think it should be, I'd see no reason not. But you made a very good point. You first determined that your patient is able to breathe in and out through the nose.
Right.
We use that taping test with children. We also have them then, but we do the nose and blocking exercise. We do the steps exercise, and then we have them walking and running with the mouth closed. Because
Hmm.
if I'll watch their breathing not just during rest but also during exercise, just to see if that child, how well can they cope with physical exercise with the mouth closed, and if they
Hmm.
can do that, I'm comfortable that their nose is working.
Right.
You said that TikTok isn't necessarily helping. I don't know. In some ways, I think it is. It's putting it out there, but in other ways, it's simplifying it. You can't just slap on tape across the mouth because
Mhm.
if you have somebody with obstructive sleep apnea and if they're mouth puffing, they need to be able to mouth puff.
Right.
What's your kind of take on that aspect of it? Since you touched on the social media, good or
Yeah.
bad?
Um, I just worry. I'm not worried about someone passing away in the middle of the night, even if they vomit in the middle of the night. And again, I may be wrong in this, but there are no known cases of someone dying from mouth taping. The drive to breathe is so strong, and the tape is so weak. Now, if you're using like a gag or a duct tape, I mean, it could go wrong. But all the mouth tape I've used, and I've tested a lot of mouth tape. Um, and certainly you could use, myotape, right? Because there's no chance. You can part your lips if you want. It's a reminder to keep the mouth closed. There are a lot of options, but I'm not worried about the health aspects of it. I'm just worried about the misinformation. So a lot of people will mouth tape, and I talked about this earlier. There are a lot of patients that can't mouth tape, and they're like, "Oh, didn't work for me." Well, they don't understand why it didn't work for them, and the pity there, the sad story there is that that was a great bit of information that they missed or their provider missed. And it means that you cannot breathe through your nose. So let's fix that. And that's what the message should be. If you can mouth tape through the night, you're a healthy person. But I think people use it as a fix for sleep apnea. Not necessarily. It's great for borderline cases, as you know. But it's just misinformation. It's kind of like the fluoride thing. It was 7 years of expert witness testimony and bringing out the science in that federal court. Started before COVID, and the verdict was favorable against the EPA. It was that there was moderate to high um, uh, uh, you know damage to the brain, possibly with fluoride levels, drinking fluoride, and that was great. And then RFK comes along and says he's going to ban it, and then that took away all those 7 years of hard evidence and put it back into the conspiracy kind of category. And that's what I'm afraid mouth tape will become, because people are touting it, people don't understand how it works unless they listen to shows like this, and then it's a fad and it passes, and then it's not discussed anymore. I would love to see dentists and physicians, especially physicians. I don't see pulmonologists using mouth tape as a differential. I just don't see it. I've never heard of that. So,
Pulmonologists don't talk about the importance of nose breathing. If you have somebody with asthma coming in, which is a condition of the lower airways, it
right,
absolutely doesn't make sense to be persistently taking cold, dry, unfiltered air in
right,
through the mouth into the lungs. ENTs, they do treat the obstruction of the nose, but they don't
mhm,
actually do follow up to see if the person's actually breathing in and out through the
right,
nose. You
right,
can't just
right,
treat the nose. You have to change the behavior. You have to
right,
absolutely make sure that, yes, if you fix the nose, it's no good unless the person is going to breathe in and out through it.
right.
So I think the simplicity of nasal breathing has been absolutely overlooked to the
Yes.
detriment of health because it's really, really powerful. I don't agree with you that it's going to not be continued. I think it is.
I hope so.
Um, I
Hope you're right.
definitely, Mark, I just because it's too important. Too many people are getting too many benefits from it. And
Yes.
yes, it may take some time for, traditional conventional medicine to start encouraging nasal breathing, but it's probably going to start from the grassroots up. And
Right.
that's when doctors are going to listen. And maybe doctors will listen when they start seeing their own children with their mouth open, or they are breathing through an open mouth during sleep, and they are
Yep.
experiencing the impact of that.
Right.
So you talked as well about you had a mince at the start, which so in terms of the foods, how then would you produce the microbiome in the mouth so that then that produces nitric oxide?
Right. Well, ideally, it should all come from diet. I've have a new appreciation for arugula salads, and one of my favorite salads is the tricolore salad, the Italian radicchio, arugula, and endive. I'll put a little uh, sliced provolone in there, real provolone, and maybe a little. The other night we had it with smoked duck, little pieces of smoked duck. You can add a blue cheese. You can add some walnuts to it. I mean that's a great diet. You can also get prebiotic nitrates in a tablet. You can dissolve that underneath your tongue, and you can get it many different ways. But it's important that you get it. And not everyone can eat a arugula salad. Uh, maybe you're eating oatmeal in the morning, which has no effect. It doesn't feed really the good guys. In fact, it feeds them the wrong food and it produces an acid attack and it spikes your blood glucose. It's the last thing you want. But adding a prebiotic nitrate, adding vitamin C with a little potassium nitrate, that combination is a great precursor in a tablet. It can be put into toothpaste. It can be put into other things as well. But if you can have that in your back pocket at all times and use that during the day, you are producing a gas that increases the dilation of all the microvessels in your body. I mean, it has immune effects. It can deactivate a virus in your lungs, even a COVID virus. It can, if you have the virus, it can prevent shedding of that virus. It can make you think better. Everyone says that a lot of the researchers, I get a kick out of this. The NO researchers always say that the canary in the coal mine is erectile dysfunction. It's
Yeah.
not. It's gum disease. It's periodontal disease. That's a microvessel disease. It's a cytokine response. It's a doom loop that once you get it, it can cause other things in the body, inflammation. It can affect, that's the oral systemic connection. It's infection, injury, and inflammation. And that's how these oral bugs create problems in the rest of the body. And the reason I say it's the canary in the coal mine is because gum disease can be seen in a teenager. It's by age 30, 48% of the population here in the US has gum disease, not ED. That comes later. So that's the canary in the coal mine, and that's what should be looked at as you are aging prematurely, and it's a microvessel disease, and your microvessels are suffering, and your NO production is probably not optimal. So again, it starts in the mouth, and then it goes to the body. So anyway, I don't know if I answered your question or not.
Yeah, no, you did.
You know,
I'm just conscious of time, and I think we've covered so much ground. I think it's been a wonderful conversation. So, as I said, you have an amazing social media following,
thank you.
whether it's
Thanks
on
to all of them.
Instagram or.
Yeah.
So, how do people find out more about you and your work?
Instagram, Ask the Dentist. We have a website, AskTheDentist.com. We have a podcast that's temporarily on hold. We've got quite a backlog. That's also Ask the Dentist. What else? We have the book on sleep. That's on Amazon. Just type in my last name. You'll see that pop up, The 8-Hour Paradox. Uh, my partner, Dr. Stacy, and I, and my daughter, we have a company called Feed Your Good Guys. And that is I think, a revolutionary approach to, and that's something I've always wanted to do, is to change the oral care. We've talked about it in the last hour. So many things wrong with oral care products. I was recommending a lot of products over time and I couldn't fully recommend them, but it was better than like Crest or Colgate. It was a lesser of two evils. And now finally, we just came to market with something that is truly oral microbiome friendly. And that's toothpaste, tongue scrapers. We have a varnish, which is a whole different topic. And then now the mints, and we've got other products coming that are NO based. We're just looking to exploit the beauty of the oral microbiome, and that's what I've been doing the last 15 years online. So AskTheDentist.com or Ask the Dentist.
Pleasure. Thanks very much. And thanks also for your interest in nasal breathing.
Whoa.
Myotape, getting the
Yeah.
mark closed. It's all good. So yeah, so that's great. So Mark, thank you very much.
Thank you, Patrick. It was wonderful chatting.